Dr. Whitehead and Dr. Capiola, you can join us now. Hi.
Morning.
Hi.
So thank you everyone for joining us for part 4 of our free webinar series, Compliments of Downtown Women OBGYN, and this week with Premier Pediatrics. We at Downtown Women are committed to your maternal well-being, not just how you are doing physically, but also how you're coping emotionally, especially during such a challenging time. My name is Golzar Selby Nakshina. I'm a licensed psychoanalyst and the director of the Prenatal and Postpartum Support Program at Downtown Women. With me today is Dr. Antoinette Whitehead. Hi. And she's a senior obstetrician at Downtown Women. She will be answering all your medical questions related to COVID-19 and the perinatal period. Now, I have to tell all of you, Dr. Whitehead is a dear friend and a wonderful obstetrician, but she has really outdone herself today. I can't believe she's here with us because last night she was on call delivering babies all night last night. So she deserves an extra round of applause and gratitude for being here with us today. Hi, Dr. Whitehead.
Thanks, you guys. It's not a problem. And don't mind me if I take a little sip every now and then.
No,
okay?
please.
Coffee.
All the coffee you want on the house. You really deserve it.
I'm happy to be here.
Also with us today is Dr. Julie Capioli, a pediatrician and partner at Premier Pediatrics. She joined the practice 12 years ago after completing her pediatric residency at Yale New Haven Children's Hospital. There she earned the prestigious Morris Krosnick Award, which was given to the senior resident that other pediatricians would want to care for their own children. Dr. Capiola is also an internationally board-certified lactation consultant, IBCLC, which is really exciting for our patients today. She sees patients at the practice's Manhattan office. Hi, Dr. Capiola. How are you?
Hello. Thanks for having me, Golzar.
Of course.
Dr. Whitehead.
We also have the wonderful Perry Thompson here with us today. She's the reason I can do all that I do at Downtown Women and is passionate about your well-being. Thank you for everything you do, Perry. Hi.
Hi, thank you all for joining us.
She's hiding. Before we start, I want to introduce the Prenatal and Postpartum Support Program. We're here for you throughout the course of your pregnancy and the first year postpartum, whether you're feeling overwhelmed, anxious, or you're not sure how you're feeling. Sorry, the share screen just ruined my text. Okay. So during this pandemic, I'm offering virtual therapy sessions over Zoom, both individual sessions and various support groups. You can also contact me for referrals. We have pregnancy support groups, postpartum support groups, and we're now adding a more didactic dads group. So email me for more information or to sign up. I'm so proud to be a part of Downtown Women, an organization that is dedicated to our patients and to our unique and comprehensive approach to OB care, which includes your mental, physical, and emotional well-being. So again, I did create a feedback form to help us better understand how to serve you in this time. It'll pop up after the webinar, and it'll be in the follow-up email that comes to you tomorrow. We'll also have a poll again during this time. There is some redundancy between the two, but if you can answer both, I would appreciate it. There'll be a Q&A at the end of this webinar, and we'll do the best we can to get all your questions answered. Some questions we received were answered in previous webinars, so you can look at the recordings that is under the webinar tab of Downtown Women's website. As promised, our childbirth education classes are now virtual. Sorry guys, you can probably hear the siren in the background. So the childbirth education class upcoming dates are Sunday, June 14th at 9 a.m. and Sunday, June 28th at 9 a.m. You can call the appointment line to sign up. We've also implemented virtual OB meet and greets so that you can be sure to meet all the OB doctors prior to delivery, and the doctors can meet you. So there's going to be an email coming up that will give you all the information. How to sign up for those is, again, to call the appointment line. They're actually really fun, right? Dr. Whitehead, you did one.
No, it was really great. We just kind of got to know patients and talked about, I mean, obviously the hot topic of COVID, but it's also just great to kind of allow people to see the personal side of us. It's a great thing for like a patient-provider relationship, and super fun as well.
Yeah, you get to know the doctors a little better, and then they get to see you without masks on. You get to see them and introduce
Yes.
your partner. It's really nice. And Perry's email is on your screen. If you look at the different pictures, you can always see her email throughout the whole event. You can email her if you have any questions, comments, or suggestions, or if you have my email, you're welcome to send it to me. I believe she already put my email up as well. So let's begin. First, we're actually going to turn to you, Dr. Whitehead, because you are probably exhausted after last night. And so we're going to have you answer all the questions that came through this round, and then we'll hear from Dr. Capiola, who's prepared a presentation about infant care and the concerns around COVID-related illnesses and children.
Okay.
And we'll do a little Q&A with her. So turning to you first, Dr. Whitehead. So a general question is about office updates. Could you update us on Downtown Women's plan to open up to more patients in June? How will these changes affect the current OB telemedicine and in-office schedule?
Absolutely. So it's been multiple meetings between the partners, employees, just like a global staff, a global approach to try and maintain our patients, you ladies, like your safety and ours as well. I just want to reassure everyone that it's been a very kind of thoughtful process to between the team at Downtown Women, and just that we're still going to be practice social distancing in a sense that, you know, we're not going back to the hustle bustle Downtown Women that people have known from the past. We're still being very careful in terms of appointment timing and seeing patients, kind of extending our hours, seeing only a few patients an hour, and that allows for you know, not having a busy waiting room, being able to get patients checked in quickly into room seen, and more efficiency, and still keeping with dividing and conquering. So our staff will be present. We still will have staff working from home, a rotating schedule. The other exciting thing that's up and coming we're looking into is potentially kind of like a virtual check-in. So we know that one way that people can be exposed to COVID-19 is just through talking and personal interactions. So there, we are looking into researching a way for people to be able to check in on Hilo. So I think that will be helpful as well. We still, even though I think we're turning a corner with the pandemic, I've reiterated this to patients and appointments, but we still have to be careful, obviously. So I think using the avenue of telemedicine, virtual visits, I think that's still going to be an option, and we still very much encourage that, so that women still we're still covering the important points and important testing of the pregnancy, but substituting in a telehealth visit here or there to make sure we can go over results, check in on you, but again, not exposing you into commuting into the office, coming in for an appointment, and then going home. So really trying to highlight in that schedule we just showed is the visit schedule that we've created as a group. But obviously, we're here if you need us every day. We still have emergency doctors, emergency slots. If patients are in between scheduled appointments, if we need to come in and check on you and the baby, that is still being implemented. And I also think during this time, we have to recognize that, you know, it's anxiety provoking. And if patients need to be seen, I mean, it's a kind of a team approach between us and patients to make sure they feel like they're getting what they need during their pregnancy.
So just to make it really clear, no partners, no kids, no visitors coming into the office. Everyone still has to wear a mask.
Correct. I mean, these are safety measures. You know, a lot of people have been still including their partners in visits via FaceTime, via phone. We are okay with that in our Downtown Women office, so they can still be involved. We still recommend no little ones. I do miss having the siblings and other little ones come in to visit. They used to be my helpers. I would put them to work to help me find the heartbeat. But again, we just want to minimize everyone's exposure. And yes, we are requiring people to wear masks to appointments. We will be masked and shielded. So again, protecting each other in that way. Visitors are allowed if patients do have, disability or need assistance, then you can bring your partner or friend or whomever with you to escort you into the office. But otherwise, yes, we haven't opened up to having visitors come into the office yet fully.
You're such a great doctor.
Oh,
You're the kid, like having that.
Oh no, I'm like, do you want to help me? Some of them are very excited about it. Other people, other little ones are not so, but I try to incorporate them in my appointment. So I do miss that. But we're hopeful. I mean, I think we just have to be very careful. The numbers are decreasing. And I think it's because people are being careful about their day-to-day, and hopefully we'll get back to our normal, or at least a new normal, where it feels like we can be more social.
Right. And so we're going to space early visits, telehealth for 24-week, and postpartum is also going to continue to be virtual unless needed.
Correct. Correct. I think it's a lot of women are still opting for that. I mean, also you have an infant at home. It's hard to even, minus a pandemic, sometimes get yourself in for that appointment. But I think it's a case by case, patient by patient assessment. A lot of women say, I physically feel well, I just have questions. Other women, obviously, if there's a physical concern, we can see you in the office and make sure that you're healing well and recovery is on the right trajectory. So I think, again, patient by patient, we can see.
And all patients should be web enabled and possible check-ins via Helo?
Correct. So I think if we go forward with this check-in via the app, that will help expedite things, keep things more efficient. Again, not so much person-to-person contact. And then also just in general throughout the pregnancy, a lot of women utilize, and even our patients, our GYN patients utilize the app to communicate with us for non-urgent questions. So it's a great way to keep in contact with providers if you have a question. Again, if it's something more urgent, that's where we need, a phone call to the office and a potential office visit. But yes, being web enabled, super important, especially if we move forward with, activating this part of Helo.
Great. Now moving into pregnancy. If New York City goes back to work in the next month or so, what do you recommend for pregnant women and their partners who are non-essential workers and can work from home?
I think we're continuing as providers to be conservative. I mean, again, with this virus, it's ongoing. Everything is still evolving before our eyes. And I think that if people are non-essential or have the capability to work from home, I've been encouraging them to continue.
Great. And what are your recommendations regarding partners and caregivers receiving the Tdap shot while sheltering in place? Can they skip it if they're sheltering in place?
I think we're really trying to still create the thought with the Tdap. Remember, it's a vaccination series that we receive as children and then boosters throughout life. And we're just trying to create that herd immunity because there's been, a lot of literature that shows the numbers are increasing in that area. And so what we used to tell partners were, they have a primary care doctor, a lot of urgent care centers, CityMD, we're starting to participate in doing vaccinations. But again, I think because of the pandemic, people are kind of holding off from that. Also, other primary care offices haven't been open to do that. I know that a lot of them are starting to open up as well. So I guess it depends what each office is, open to doing during their visits. But I think for now, we've been directing people to, NYU has enough supply to be able to vaccinate partners on the postpartum or the mother-baby floor. So, while, mom is there recovering, we can vaccinate the spouse. And I think that that's helpful. I don't know, Dr. Capiola, if you have any other thoughts about that, just from the pediatric perspective.
You're muted.
Our office offers them as well. So if you're coming in anyway, if there's an older sibling, or postpartum, obviously, if they're coming in for their first newborn visit, that's another reasonable way to access it. But pediatricians are very pro-vaccine. And in the time of a pandemic, that's when we can have outbreaks of vaccine preventable illness. That's super important to prevent.
It's an excellent point. Yeah.
So
great. I didn't know that that was an option. So I will tell our patients that as well.
See, even we learn in these.
Yes.
All right, so moving into hospital and delivery, my husband and I took the Ready, Set, Baby NYU webinar, and it says to go through the main entrance. We confirmed that information with the educator after. In the Downtown Women webinars, another entrance was mentioned, so now we're not sure where to go.
So just to clarify, I think we're all on the same page. I normally tell patients, so where you're entering is off of First Avenue. It's a half circle drive. Again, away from the emergency department, so you don't need to worry about exposure as you come into the hospital in terms of sick patients. So that is a different entrance. And also, again, we talked about this in previous webinars that they are our patients that are sick with COVID are in a different pavilion part of NYU. So the entrance on First Avenue, as you enter, the great thing about it is that 24 hours, 7 days a week, there's always somewhere to assist you. Even if you're working through contractions, laboring, there are lovely security front desk staff that can help direct you. So there's 3 pathways and everything is color coded at the hospital. So it's the blue pathway off to your left. And then you're going to go, there are 2 elevator banks that you can take up to the 8th floor. Either one, I would go with the one on the right. It's faster to get to. I just remember about my experience coming through Langone laboring. So just to streamline, but you'll take that up to the 8th floor and then we'll get you checked in there. So I think we all probably explained it a little bit differently, but First Avenue, half circle drive, you can't miss it. Do not go to the emergency room. They tend to, when people show up with babies in their bellies, they sometimes forget that obstetric training and then they just whisk you back to us. So just to come right in and they'll help direct you to the elevators, to the blue pathway.
So it's all the same. Whoever you
Correct.
it's all the same.
Yeah.
Will my husband be able to come to triage with me?
Absolutely. Remember, this is why we're NYU strong. We have, from the beginning, really supported women having a visitor, not having women labor alone. So yes, absolutely in the triage check-in point, we're asking that families can come in together, bringing all their materials, like a car seat, definitely some snacks, which we can talk about that in a moment, just about services that are available in terms of food. Yes, spouses, husbands, wives, partners stay the entire time with you, even in the triage check-in point. And remember, in terms of screening for partners, we are still doing temperature checks and a respiratory questionnaire. So asking if they have any COVID symptoms. We are not screening partners. And this is because by screening the patient, there's a lot of literature to say there's a 99% concordance. So if women are screening negative, the high likelihood that the partner's negative. So again, they will come in with you, be there, our plan is for them to be there to support you the entire time.
Great. Does the hospital provide masks to wear during labor? I have a mask, but I find it very difficult to breathe while wearing it due to a general shortness of breath during pregnancy. And I'm wondering if the hospital has better options or if someone can recommend something I can buy beforehand. Would have been Dana's.
So yes, we're asking everyone, so the trip into the hospital, keeping covered, being in the hospital, wearing a mask, I think it's difficult. I think for us as well, and I can't imagine a mom what our patients go through in terms of coming in for delivery, whether they're laboring or even for my moms that have C-section delivery. So we do have masks. If you need them, I think that what some people have found more comfortable, or what I have found more comfortable, is a cloth mask. I was telling these ladies I have a really fun one that says super mom, super wife, super tired on it. But I find that one's a little bit easier, but to breathe with. So I don't know. I think if I had to put on a scale of what's more uncomfortable, probably the hospital mask. But I think, if you are this morning, I was pushing with a patient in the second stage of labor and it was uncomfortable for her. So, but everyone else in the room is masked and protecting. So I think, in an ideal world, yes, but I think getting through the birth is most important and we will still be protecting you from us.
So to be clear, they can take the mask off.
Correct.
Right. I was telling the ladies last night that I've been wearing a silk Hermes scarf, thinking that that would be a good mask alternative. It is not. Silk is free through. To God. At NYU, if a mother tests positive for COVID and is asymptomatic, can she decline mother-baby separation? If I am symptomatic, is there a liability waiver I can sign to decline separation? So I want to hear from you, Dr. Whitehead, and then I do want to turn over to you, Capiola, after Dr. Whitehead.
Yes, so from the beginning, and I think this is the great thing about the masterminds of infectious disease, maternal fetal medicine, so our high-risk specialists, infection control at the hospital, is that we really try to weigh risk and benefits. And so a positive COVID test, because we know that there are some people that are asymptomatic, it doesn't automatically mean separation of mom and baby. I think that in terms of where patients are positive and symptomatic, that's where the separation may come in, just because if people are having fevers and their coughs, that's how we know that things will spread. And I think that in that case, patients are very, very ill. So I think, yes, there can be discussion of risk and benefits, but I think at that point of where patients are really sick, they're not even really in the state to be able to take care for the baby the way they should. But yes, it's a global discussion. It's a patient-centered approach. It's a discussion of risk and benefits that can happen. But in the category, or kind of thinking about how the virus presents itself, especially for women that are very symptomatic, they're not in a well enough state to kind of care for their babies in general postpartum. I don't know, Dr. Capiola, do you have any thoughts?
Yeah, as a pediatrician, what's your perspective?
Certainly moms need to take care of themselves first, right? It's the same principle as when we're on the airplane and we have to put the oxygen mask on ourselves first before we care for our children. So I think Dr. Whitehead's point is super important, that a mom who can't take care of a baby if she herself is not feeling well. But the American Academy of Pediatrics and the CDC, the Centers for Disease Control, have these recommendations. And we're just really primarily trying to look out for the health of this innocent, vulnerable baby. And so sometimes that temporary separation is necessary, and it's recommended. It's not mandatory, but it's hopefully brief. And because we know that the primary way moms give it to the baby is through the respiratory droplet after birth, after delivery. So the AAP still says express milk and provide breast milk, but it's recommended to temporarily separate. That may mean in the same room as mom, but in an isolate, so that there's another, degree of physical separation. So it's not hard and fast somewhere else in another area of the, the nursery or the hospital, but that is the recommendation.
I have a lot of patients who are worried about losing the opportunity for skin to skin, or how it's going to impact breastfeeding in that initial separation, and have the feeling that avoiding that separation is better for them and the baby. Do you have any ideas around that, Dr. Capiola?
Obviously, the ideal is to have that skin to skin right away, and to provide all of the newborn care with mom, on mom. I'm a lactation consultant, so this is true to my heart. But in a time when mom is ill, we have to look out. We have to put the risks of that exposure outweigh the benefits of that connection, unfortunately, in this case.
Just to kind of piggyback off of that, I think it's just very hard, and Dr. Capiola, you can state your opinion as well, is that we just don't have the sound data yet to say, we can say with 100% certainty this outcome will be, X, Y, or Z. So I think we're cognizant. Remember, that's why we love NYU. We are baby friendly, but I think we're just trying to, in this setting, balance the risk and benefit ratio.
It's so hard with the limited information we have, and week by week, month by month, there's more data and more information by which we can make these decisions.
Thank you. I heard that doulas are now considered essential healthcare providers. Does this mean that we have a partner in addition to a doula present for birth, or can you still only have one person physically present?
Yes, so in the last few weeks, we've had our doula colleagues come back. I still think it's very interesting that some people are still using them as a more of a virtual presence or an at-home presence. I think that some families are concerned about exposures as having another person in the room, and I think the doulas themselves are concerned about it as well. So I don't know that everyone's back in the field working, but I think that they are required to wear personal protective equipment. There is a sign-in process, but we have had a few doulas come back. I think that if people are trying to consider if they would want someone to help them through their labor journey, but they're nervous about having another presence of someone at the hospital, I think a lot of people have still had very great birth experiences and successful journeys through labor with having the doula labor with them at home, and then be more of a virtual presence via FaceTime or on the phone at the hospital, or on FaceTime and on the phone the entire time as well too.
So some are choosing to stay virtual. Do you think that it's helpful to have a doula in this time for all that prenatal and postpartum support?
I do. I think, in general, I love doulas. I think it's about 30% of our families utilize them. I think even more now, building, we were, chatting about this before, that village around you and having people to support, whether, it's your team of doctors, our goals are in peri, you have family, friends, colleagues, which that can be somewhat limited at this point. So I think that some families have been interested, even pre-COVID, having doulas more for like postpartum support or lactation support, or some people just pre and not necessarily for the labor. So I think it is very helpful, especially now when people feel socially isolated. But I think every family has to do what feels right for them.
Great, thank you. And are women still allowed to walk through the hallways during labor?
We know that movement is important, and sometimes if women are in early labor, we encourage them to walk. But I think what we've been able to do now that we're seeing a trend at NYU that kind of the numbers of patients that are coming in is lesser, and I don't know if people have lesser pregnancies right now, or if people, because of COVID, have relocated to different places. But I think because things have been a little bit lesser, that women are coming and laboring, and then we can get you quickly into a labor room and kind of use that space in terms of movement. So yes, we try to avoid walking in the halls just because that's, again, exposing you to other people. But I think the nice thing is that we're able to get patients into, like, from the triage check-in point into labor rooms more quickly right now.
Could you discuss natural childbirth in the hospital and birth plans?
Absolutely. I think the great thing about our practice is that, and I think patients who are interested in unmedicated birth and natural childbirth mostly come to our practice in the all lady group, Spring Street OBGYN. But obviously we support patients no matter what their birth plan or preference is. And so we have the ability to do intermittent monitoring for patients that they want to move more, or even if women are interested in an epidural, but they're not yet ready for it. We do have wireless monitoring at NYU, so that gives patients more degrees of freedom. I think if you take a look at the sample birth plan that NYU created, and I think that it's phenomenal that a hospital would generate a birth plan. Most people think of hospitals are a place that really are not interested in hearing from patients or helping them have a very patient-focused birth. But I think NYU is great. It's a great balance between holistic and having a hospital setting with more resources. So I would encourage everyone to take a look. You can go to nyubaby.org. And we also give it we have copies of it if you're in office visits. to take a look at that. You can download it off their website, and it's a good, I think, a discussion piece as you start to think about and plan for the day of. So that actually might generate some questions for you to ask us as your team.
Great. And what is the current situation with private rooms at NYU?
So remember, private rooms at NYU, they are based on time of delivery. I think that because a couple things that have happened during the pandemic that are continuing, and we'll have to see for our ladies who have later due dates as we go through 2020, but we have been encouraging early discharge. So if women have a vaginal delivery going home on day 1, if women have a C-section delivery going on day 2. So this has helped with social distancing on the mother-baby 4, so that if women don't have the opportunity for private rooms, that if you're going into a shared room or a shared space, they're really trying to keep that bed or that shared space open. So I feel like there's, in that sense, there's much more, we don't have an increase in number of rooms, but because we're trying to do that, it allows for family to have kind of that more private recovery time.
And there's just plenty of room and space because there's so few people delivering right now.
Yeah, it's a little bit different time right now, for sure. But again, I can't tell you how I feel like this has kind of been my glimmer of light through all of this, is that women are still having very healthy births. A lot of people have conveyed to us that they, like, I just delivered a patient's 3rd baby, and she said, you know, I was really worried about what the environment and what the vibe of the hospital would be like in comparison to my other 2 deliveries. And she was just so happy and just kept saying, and so grateful, you know, for our care and the nurses' care, and just globally that the staff, you know, you wouldn't even know that there's a pandemic going on outside. So
wonderful.
Yeah.
Do we bring the car seat into the hospital with us when we deliver? I know we need one to leave with the baby, and was told my husband can't leave once he comes in.
Correct. So this is a little hard just because we're asking you to bring more things with you. But again, to protect you from kind of the leaving the hospital, going to the environment, having more exposure, coming back. So yes, bringing the car seat with you so that, and also this is a nice review. This is a great slide of, you know, bringing the car seat so you're ready to go home together as a family. Snacks are important, and our cafeteria is open and functioning, which I feel like they keep just getting better and better. It's not your normal hospital cafeteria food, which is awesome. But I think we have been trying to keep food delivery out of the hospital. So this is why I said bring some snacks, maybe something, you know, light, that if it's, you know, middle of the night, you're up, you're feeding the baby, you just labored, you know, you guys have been up laboring for a few days, you have a little something to get you through the night, but the hospital cafeteria is still functioning. Partners can go downstairs and grab something from cafeteria and bring it back to you, but we still have the ability to have meals, you know, coming to the room every day. An outfit for the baby to come home in, nursing bra, breastfeeding pillow if you want. But a lot of people, I feel like they're kind of minimizing bringing pillows and just kind of sticking to clothes, toiletries, kind of just basics. I want to dispel the myth. There was, at one point, I kept getting a barrage of questions about postpartum supplies or baby supplies. We have plenty of diapers, you know, witch hazel pads, Pericure bottle, I mean, everything that women would need. So I'm not sure that where that was posted. So I just want to, again, reiterate that. So I don't think you need to start packing all of those things up, but this is a nice kind of concise list of what we think is needed right now.
And I know that in a little bit when we hear from Dr. Capiola, she is going to agree that a breastfeeding pillow is a good idea. So we'll hear about that a little.
I know.
I was going to put in the plug.
I guess it's not that it's a bad idea. I guess I'm sorry. I'm just speaking from what I've seen people do. It kind of has changed over the last month, but you can bring it, totally bring it. Look, I'm getting myself, Dr. Capiola is going to get me after this.
So you preempted my next question, which is partners can eat at the cafeteria, but they should not be ordering outside food to NYU.
Correct.
Great. So we will move into postpartum. Have there been any changes in the policy regarding our immediate postpartum hospital stay for both mothers and birth partners?
I think the only change, really is the encouraged early discharge. And again, this is a case-by-case basis. So in the last several weeks, if the baby needed some follow-up testing, like from our PEDS team, or if mom's having a longer recovery, and where the traditional time is 2 days after vaginal delivery and 3 days after C-section. So, I think, again, a case by case, that's really the big change is more of the early discharge. I think other things that have slightly shifted for postpartum is we've lost our latch hour, unfortunately, but our lactation consultants are rounding. So still getting in some good at the bedside one-on-one work. A lot of the nurses are certified lactation consultants, which is great. On labor and delivery, postpartum, a lot of them are moms, so they come from personal experience. So I still think even though we don't have the latch hour, we still have the resources there to help women. But I think that those are kind of the biggest changes that I'm seeing.
So no latch hour, but they're still getting a lot of one-on-one lactation support in the hospital.
Correct.
Good. In the unlikely event that I have a roommate in the hospital, how should I behave given social distancing guidelines, and should I be concerned? Now, this would be assuming that both people in the room have already tested negative, right?
Correct. So I think now that we've moved to universal screening of moms, that we know that if by chance it's a busier few days on labor and delivery and postpartum, that other person has been tested and screened. So whereas before you did not know the status of the roommate. So I think that that's very reassuring, but I still think I would still recommend continuing, to mask, good hand washing technique. There's hand sanitizer in the room. I still think because, it is a hospital, like you should still be protecting yourself in that way. So I don't want people to become completely lax because they say, oh, it's a negative test. I would still recommend doing all of those things, but it still is reassuring to know that if you do have a roommate, they've been screened.
Great. And can you go over the length of stay and discharge policy for vaginal C-section births? And more specifically, like if you gave birth at 10 p.m. on Friday, when would you be discharged and could you stay longer?
So normally we do 24 hours for vaginal deliveries, 24 hours of monitoring moms and babies. And this happens as the women, they deliver at 10 o'clock at night or 11 o'clock at night. I've had a few people sneak out in the middle of the night, but I feel like if you're really delivering that late, I'm always COVID, non-COVID, I don't like discharging people late unless they really want to run away. So I always encourage the next morning and we can prepare things for then. So.
Great, thank you. Now we're going to move into general anxiety and COVID before we go into pediatrics.
Sure.
Can you talk a little more about postpartum life in this time of COVID-19 beyond the logistics of visits and care? How can we deal with the desire to be active to create memories as a new family and with extended family? How do we continue to set boundaries when our families are feeling the pain and separation that comes from social and physical distancing?
I think to start, I just think you should take advantage of, just checking in. And I think virtual things have been great. We've had 2 virtual birthday parties, myself and my spouse, in the last 6 weeks. I think that, I think reaching out to people in that way, and I know it doesn't take away from the actual physicality of being able to hug or be close to, your loved ones at this point. But I think that balancing, we really have to be careful. And I think Dr. Capula will talk about getting home and considering like bringing family or friends or nanny. We'll kind of talk about, we'll get into that. But I think, at-home workouts have been great and lifesaver. I mean, I'm not postpartum, but I've been referring patients to kind of look for postpartum, as they're getting towards maybe 3 to 4 weeks out, some postnatal workout. Meditation has been huge for me. I keep telling everyone, meditate, meditate, meditate. I think,
Telling you last night.
Yes. And so I think, those are my nuggets of wisdom. I think that, our normal is different right now, but I think if we can still just kind of cling to each other in that way, even though it is virtually or phone call, I think that that's really helpful. I don't know. And, we have great research. We have Golzar, we have Perry here, we have our team. I don't know, Golzar or Dr. Capiola, if you have any other thoughts.
Yeah, before we ask you, Dr. Capiola, I would like to say that keep in mind that we have tons of resources at Downtown Women. If you feel like it's affecting you mentally and emotionally, we can help you through that. We got some really great postpartum groups that are actually fun, and the women are building wonderful relationships with each other. And I think that it really does help ease something and feeling understood by others. This is temporary, but there is a reality that you wouldn't be out and about so much if you were postpartum anyway. And so while that can feel frustrating to hear, it's also just true. And I think when it comes to setting boundaries with your family, blame it on your doctors. Tell your
wide shoulders.
Tell your in-laws, this is what the doctor recommended. These were the doctor's orders. This is what Golzar said. I mean, really use the professional opinion that you are getting right now and cite it. And it's sad, but they will get to have that time with the baby soon. And Dr. Capiola, I don't know if you want to touch on it now or if we should wait until later, but I know you're going to talk about how long to set those boundaries for and really the reality of social distancing right now postpartum. Do you want to touch on it now or should we just wait until later?
I'll put in a plug for I'm always willing to accept the blame. I tell all my patients, hey, Dr. Julie said it, and it will work. Usually, for the first 8 weeks, that cocooning is really important. And in general, we recommend very few visitors, even outside of the time of COVID, because of the risk to the baby with their vulnerable immune systems until they are 2 months of age, and also receive that first set of crucial vaccinations for things like whooping cough at that 2-month well visit.
And, early postpartum, it's not like you're missing on the opportunity to experience the outside world with the baby. The baby's not really doing anything. Just enjoy the skin to skin, because that's what really matters at this stage. Do either of you want to add anything else before we move on? I know that was probably not a very helpful answer for a lot of you. What will happen after the lockdown eases?
Well, that's a tough question. My hope is that things, I think, will continue and gradually to get better. I think for now, this is our new normal. And I think our new normal for a while. I think we're still going to be slowly coming together, but still social distancing. I think, we as a team at Downtown Women, actually, we were just talking about this. I think, we talked about kind of opening up like June 1 on Monday, and then what do we do for July? And I think the consensus is that we're still going to have to maintain, that's our way to maintain safety or keep numbers low. I'm hopeful there's not a resurgence, but we can only take it one day at a time. I don't know, Dr. Capiola, what do you?
That's all we can do. We all hope there isn't a second wave, but we'll prepare when the time comes if there is. And for now, just deciding everyone's risk that they're willing to accept. And then moving forward, making decisions for your family, thinking about the possible risks with each exposure.
And if you're more risk adverse, then have those conversations with your friends and the people around you, and follow your instincts always. Do you have any information on men and partners' experiences in this time? I'm really excited about this question. Dr. Capiola, do you want to touch on this first, and then I'll speak to it?
Okay. So I think that since the beginning of the pandemic, we have limited and tightened the circle that is, with mom and baby. And that a lot of people have postpartum doulas and extended family. There is this, like, it takes a village to raise a child thought. And it's always been true. When I was postpartum with my first two children, I was lucky enough to deliver in the summer. And my mom was a teacher. My mom is a teacher. And even though I'm a pediatrician and I'm an expert in newborn care, my mom came to help me. In a time like this, my mom is 70. I personally probably wouldn't have had her come. That's my personal decision if I were having a baby now. And we'll talk about a bit about that going forward. I think what that does is it puts a bit more pressure on a partner to be sort of everything else in terms of a support system. So that can put a lot of emotional and mental strain on someone who maybe wasn't prepared to be that level of a partner for a postpartum mom.
Yeah, I think that that's really a big thing to consider, is that there's a different kind of pressure like dads are facing right now, and partners. I don't want to limit it to dads. This was a male focused question, and I think there's some slight difference, but yes, a lot more pressure that you have to suddenly come to terms with and figure it out. And you probably don't have the communities of guys to talk to, which is why we are starting a dad's group, so that I can actually help you guys through that with both the didactic stuff and the group support of how other dads are coping and just not feeling alone in that in this time. Also, you're super isolated because you're probably working from home. So not only is there all of this pressure for you to help postpartum, this thing that you definitely have never wrapped your head around. Like, moms haven't wrapped their head around it if it's their first time, but dads surely have no idea. And so there's all of that pressure, and then there's the working from home, and there's the isolation, and there's just the general pandemic anxiety. That is a lot. That is a lot falling on your laps, and your peers probably don't have anywhere near that experience in their postpartum experiences. You know, friends, family members who didn't have children during this time. There's also the fact that you guys have been locked in a home together for longer than you probably ever thought you would be together when you decided to marry each other or be together, right? So there's all of the marital pressure that's coming from being quarantined at this time, and then that's coming from having a new baby, because new babies really impact marriages. I say this sometimes, that some people get really mad at it, but I'm gonna say it: babies ruin marriages, and you have to fight them. You have to fight the baby to save the marriage. And so, you know, that pressure is now coming in. And when women become pregnant, they start to come to terms with motherhood, with becoming a mother, with sacrificing for a baby, because they have to do it in what they eat and how they walk and what they do in their whole lives. When they become pregnant, changes, and they start sacrificing. They start to really lose their independence during pregnancy. But the reality is that men, they don't have to sacrifice, and they don't become a parent until the baby is born. They say that women become a mother when she becomes pregnant, men become a father when the baby is born. And so since there was nothing tangible yet for you to really come to terms with that loss of independence and that shift in sense of self, that all really starts to hit you postpartum in the middle of all this other stuff we talked about. So I do think it's really important that you are also getting a lot of support in this time. And again, you can always email me or Perry to learn more about the group. It will be a little more didactic in nature, but I do want the men to be able to form bonds in it. So that is my very excited spiel about how men are doing now. Do you want to add anything, Dr. Whitehead?
No, that was fantastic, ladies. Good.
All right, so with everything changing and no one knowing when things will stop or open, and New York being a city of women who plan, how do you not feel like you're going nuts trying to think ahead? And I know we have a webinar full of planners right now, so any insights on that?
No, I think that's the nature of, I don't know, I don't even know that's the nature of being a New Yorker. I think it's the nature of being a woman and wanting to be prepared and stepping, as you said, into this new role. And, you know, you have to think about like childcare and going back to work. And there's all these different components, which, throwing COVID-19 into it does make it more complicated. And again, my mantra, like at this point, is one day at a time, because things are evolving. And I think if you keep trying to, normally we can traject out and kind of think about the different outcomes and what things will be. And right now we just don't know that. And that's the hard part, and trying to rest in that and say, okay, this is not my normal mode of operation, but I'm okay. And I can tackle kind of one thing at a time.
And I think it's, for those of you who are, I don't know if this question came from somebody who was pregnant or not, but I think one of the hardest things for women to cope with postpartum is that they are these type A, super efficient, very organized women who've survived in New York and been successful. And then all of a sudden this baby comes along and that ruins all of that. And it's really hard to wrap your head around it. And I think that is where a lot of postpartum mood disturbances actually originate in New York. And so the fact that you are getting a little taste of that, and like that, that the pandemic has kind of titrated your ability to control the things around you, might actually set you up for a better postpartum period, in that it's a little more normalized to be out of control, because kids are going to keep you very out of control. What do you think, Dr. Capiola?
We can only be good at one or two things at a time, not four. Like, I'm at home, I feel like I have 4 jobs and I can't keep on top of all of it at once. And we just have to let that go and forgive ourselves. We can't be perfect at everything. And I am most certainly type A as a physician and an overachiever my whole life. I suspect Dr. Whitehead may be the same. I don't know for sure.
Agreed.
A pandemic definitely teaches you that you can't be in control of everything in your life.
So maybe enjoy it and learn from it. That might be the most annoying answer. Okay, we're going to move into, Dr. Capiola has a presentation for us. Dr. Whitehead, do you want to go take a nap?
I'm okay. Have you seen me starting to lean? Just like.
Just make sure you have a pillow next to you in case you fall off your chair.
My bed is behind me. Don't worry. I'm
Perfect.
good.
Okay, so I'm going to put the poll up. So if everybody could just quickly answer the poll so we have an idea of who came from where and who we have in the audience. And I'm going to go ahead and turn it over to you, Dr. Capiola. So.
First, I want to say thank you so much again for having me. And I have to put in a plug for Downtown Women. Dr. Whitehead delivered my 3rd little guy, and it was the best experience. I loved delivering at NYU, and she was such a partner with me in delivery. I think I was a crazy lunatic when I had him.
Not at all. She's not.
She's not, but that's okay. All right, so let's talk a little bit about delivering in the time of COVID. This is weird because I actually see the poll now in front of my words. Okay, that's okay. We'll work around it. Don't worry. Leave it up. So first things first, vertical transmission is something I wanted to talk a little bit about. And that's where the mom would pass the infection of COVID-19 if she is infected to the baby during the pregnancy. And that is more of a theoretical issue, and it turns out there may be some of this vertical transmission, but it seems exceedingly rare, and there aren't any obvious known positive cases of vertical transmission mom to baby during the pregnancy. So we know, or we postulate, and with some data, that the primary mode of transmission is postpartum via those respiratory droplets. And this is the reason for that temporary separation as recommended by the AAP, the American Academy of Pediatrics, and the CDC, as Dr. Whitehead was already talking about. So even if a mom is positive for the infection of COVID-19, breastfeeding is still encouraged. There has been no documented transmission of SARS-CoV-2, the virus that causes COVID-19, via breast milk. So that's really important. And that was also shown in these prior coronaviruses like SARS-1 and MERS. So the AAP and the CDC still say express milk. Now it's important prior to expressing to wear a mask, cleanse hands and with soap and water, and also wash the breasts for that good like 20-second sing happy birthday twice rule. Prior to either breastfeeding, if one chooses to, or to expressing milk with a breast pump. Also with manual expression, which is actually a super important way to express milk in the postpartum period, much better and more efficient than with a breast pump in that immediate postpartum period. I mentioned with direct breastfeeding, that same hygiene is important if a mom chooses to breastfeed and not follow that recommendation of temporary separation. And that temporary separation is recommended to continue until mom is well. And that means now, according to the CDC, about 10 days from the symptom onset, or say if mom was asymptomatic, but she tests positive, it would be 10 days from the test, from that positive test, as well as 72 hours fever-free with improving symptoms. So that's the symptom criteria. Then there's also a testing criteria for stopping that temporary separation, and that would be 2 negative COVID tests about 24, 48 hours apart. That's a little harder to obtain at this point. Mostly we're using the symptom criteria, the 10 days from symptom onset and 72 hours fever-free. Okay. So let's talk in general about feeding in the hospital. This is not specific to COVID-19. I think we all need, some advice, especially if it's your first baby and you've never done this before, about sort of what's normal and common and what to expect. We can prepare ourselves for some things, ladies. So rooming in is always recommended for breastfeeding success. And that's part of the baby-friendly criteria and protocols that NYU employs, since NYU is a baby-friendly or breastfeeding-friendly hospital. Very important to have frequent and early breastfeeding if mom is choosing to breastfeed. So early skin to skin, latching baby onto the breast in that first hour of life, ideally. When the baby has that first hour, a very alert period. The following 23 hours, most babies are quite sleepy, and this is important to understand and know. Sometimes there's a very successful feed in that first hour, and then the rest of the 24-hour period doesn't go so swimmingly. But you want to try to get that baby to latch on every 3 hours or so. If it's not successful because the baby's too sleepy, you want to try some manual expression. Like I said, that's the best way to express milk in the immediate postpartum period. But at least try every 3 hours to get the baby to breast. Now, after that first 24 hours, 8 to 12 feeds every 24-hour period to help establish mom's milk supply and keep the baby hydrated and nourished. Cluster feeding usually begins after that first 24 hours. Sometimes I walk in to see moms postpartum when we are actively rounding at NYU. That for, it's less than 24 hours since the baby was born, and the mom's like, the baby is a great baby. And then I'm like, well, just prepare yourself because usually tonight doesn't go so smoothly. But cluster feeding is normal. And this can look like a baby nursing for 45 minutes straight and then off for 10 minutes. And then the baby's starting to root and suck on the hands and looking hungry and ready to feed again. And this does not mean that mom isn't making enough milk and that things aren't working. This is a normal feeding pattern. And again, that goal of 8 to 12 feeds every 24-hour period after the first 24 hours of life is crucial. Breastfeeding, and I think this is a very important point, is learned. And people think that because breastfeeding is natural, that they are like one with Mother Earth, that it should be easy. But it usually is not easy. And I think that's very important for a mom who is delivering for the first time, it's her first baby. That is learned for both of you. It's a learned process for mom and the baby. And then I will tell you, even I was surprised when I had my second and third, that breastfeeding was actually uncomfortable because my second and third babies, even though I was an expert breastfeeder, I had nursed my first for 20 months. It was painful for me because they had to get efficient at latching. And that can take a couple of weeks to kind of get in the rhythm of things and for the baby to learn how to pull that nipple in and latch on properly and extract milk. So just know that it's going to take some time. And sometimes it can take up to 12 weeks for that breastfeeding relationship to be sort of easy and feeling more natural. So that's a long time, 12 weeks. But I think it's important to partner with your pediatrician and set goals with your pediatrician. We listen. That's what we're here for. My goal is not to push breastfeeding on you. It is to help you find out and figure out what your feeding goals are, and then to partner with you so that we can help you reach those goals. And that's if you decide to formula feed as well. There is no judgment. I'm a lactation consultant, but I will never put pressure on you about it, and neither would any of my colleagues. So it's important to partner with the pediatrician, and we listen to you, and we will help you reach your goals. And here's what I wanted to say. I would recommend bringing a breastfeeding pillow to the hospital because the pillows in the hospital are not so great for support. And when a mom is postpartum, whether from vaginal delivery or C-section, it is so physically uncomfortable that the pillow will allow you to support the weight of the baby. And then your hands are available for just positioning. I think that's really important. And then sometimes you need partner's hands on board as well if your partner's there. Can't have too many hands when you're trying to get a baby latched on properly. So I do recommend bringing that pillow, since no one will be able to bring it to you once you're already there. So
Listen to Dr. Capiola, not me. I'm going back to the pillow. I'm just teasing you. Bring the pillow.
Okay, so when you go home with your baby, it is very important that there is an in-person pediatrician follow-up appointment. Usually we say outside the time of COVID, 2 to 3 days after discharge, particularly if you're breastfeeding. If you're formula feeding, there's often a little bit of wiggle room because then we're actually quantifying. We know exactly how much volume the baby is getting at each feed. Now in the time of COVID, because of the early discharges that Dr. Whitehead was speaking of, sometimes babies and moms are leaving the hospital 24 hours after delivery. We often need a follow-up 1 to 2 days after discharge. So the pediatrician in the hospital will let you know how quickly to follow up, but this would be our general rule. And that's important because we need to, the baby's circulation and body systems are changing from that fetal circulation, that circulation of the baby, the baby's blood inside the uterus, to a different circulation outside. And so these changes happen, and we need to assess for any problems that can arise during that time. Also, babies can lose weight quite rapidly. And babies that lose a lot of weight can get into a cycle where they get tired and then they don't feed well and then they lose more weight. So it is important to break that cycle early on. And that in-person weight check is important. Also, we're looking for jaundice or elevated bilirubin levels on physical exam. So also at that first office visit, we're reviewing very important, the perinatal history, mom and extended family histories, so that these are things that we can look out for any issues going forward while we're your child's pediatrician in the first 18 to 21 years of your child's life. And then if not given in the hospital, the first hepatitis B vaccine is offered in the office, although it is recommended to get that in the hospital as well. Either way, I think is fine. After that first in-person office visit, weight checks should happen every few days, typically until the baby is on a good weight gain or back up to birth weight, give or take. Now, sometimes these weight checks can be done virtually. Now, it would be important to have access to a scale of some sort to do a virtual weight check, because a weight check isn't a weight check without a weight. So that happened to me when I was doing a telehealth visit. We didn't have access because Amazon was delayed and such. Ideally, you have some access to a scale. People use the Hatch scale. They've borrowed scales. They've ordered from said Amazon. Some people have used pastry scales with a bowl, and then you zero out the scale and stick the baby in the bowl and do a weight. And that can give you pretty accurate weight. And then you have a comparison from that first in-office weight check. And then you check in with your pediatrician virtually so that we assess the baby's feeding, do like a quick look for jaundice, and then come up with a feeding plan going forward. Once the baby's back up to birth weight and doing well, the next official well visit is in the office at about a month of age. So it's important that we know the baby is growing and thriving up, and so that we say, hey, I'll see you in a month. We want to make sure everything's going as smoothly as it can be. Frequent feeds need to continue until the baby is gaining well. So I usually say that 8 to 12 feeds a day should happen in the first 2 weeks of life. Some babies are not trustworthy and they don't always wake up to feed. So I usually encourage moms to think of that goal of 8 to 12, and then you spread it out over the course of the day. Some babies can feed like hourly for a few hours and then go a 4-hour stretch. But if that goal of 8 to 12 is in the brain and in the app that you can download, you'll know your baby is getting enough. And this also helps establish milk supply of nursing. Okay. So I mentioned it takes a village. We need help with our newborn. It is so difficult to do this, even with just a partner. So first I want to talk about the doulas, postpartum doulas and lactation consultants. I would recommend probably that since we're limiting the circle that's around the baby, that you use only one virtually at this point in the state of a pandemic. Now, when we talk about night and baby nurses, you want to really think about the risks and the benefits. So for some moms, we need to look at maternal well-being, and you need to take care of yourself first. So if you and your partner are going to be unable to handle this, and you maybe have the money to pay a night nurse to quarantine for 14 days prior to coming into your home, and trust they will quarantine, you may be able to have someone like that. But you definitely want to be in a position where you can trust that person is isolated for the prior 2 weeks. And it probably wouldn't be fair to ask someone to do that without some form of a payment. Otherwise, I would recommend it just being you and your partner if you have. Now let's talk a bit about grandparents and other family members. And these would be other family members that might be just staying with you, like someone in place of a grandparent, not people coming in to visit, because we'll talk about that in a moment. So first I would like to say, I would consider a 14-day quarantine for anyone coming to stay with you. And so if they're coming, especially if they're coming via flight, they should maybe come 2 weeks prior to when you're going to have them stay with you, and then quarantine for the 14 days prior to when they come into your home. We also need to consider the risks of a grandparent, an older caregiver who may be in New York at the time, who would be in New York at the time of a pandemic, and the physical risks to them. So since you've been in the hospital, and even though things are tight at NYU and the risks are as mitigated as they possibly can be, if the person you would have coming into your home is a high-risk individual, you might want to consider waiting 2 weeks for that person to come to your home after you return from the hospital for their own safety and protection. In general, I would tell you that I would not have other extended visitors into your home. In general, when you have a newborn, outside of the time of COVID, I recommend limiting visitors into your home because babies do not have immune systems that can fight off general infections that we have. And so we want to be extra cautious, but now in the time of COVID, even more so because of the level of asymptomatic or pre-symptomatic to COVID infection transmission that happens. We know that a big portion of the transmission of COVID happens prior to anyone having symptoms. So it's even more important now. And I would also avoid any sort of what's starting now, these socially distanced hangouts, even outdoor barbecues. I wouldn't do any of that with a newborn up through probably the first 8 weeks of life until that baby has a stronger in general immune system and receives the first set of vaccinations. And then at that point, we look at sort of where numbers are in your community in terms of COVID, and then make decisions in talking with your pediatrician about the risks or possible risks, and then how to mitigate them. Okay, so siblings. I think this is important in general to talk about, to teach siblings how to be near a newborn. So we want to teach them how to interact safely and what is safe touch for anyone actually with a baby. So I usually, even grandparents, no one should be touching the face or kissing the face of the baby. I know I'm Italian, so everyone's like squeezing and biting cheeks. That's like part of our Italian American culture. So we want to avoid that. It's very hard, I know, for grandparents to do that, but safe touch, I tell parents to teach the siblings, kisses to the top of the head and to the feet. I think those are safe places, and try not to have the, siblings sort of mauling the child, sitting in the bouncy seat or hanging over the bassinet. So this is a general lesson, for all siblings in all times, not just in the time of COVID. In terms of COVID, siblings are probably safer right now than they normally are when kids are sort of in general in schools, in daycare centers, and having play dates and going to classes all around the city. So it's a little safer from that standpoint. So these would be reasons in general to seek medical care with your baby under 8 weeks. So it's important to have a rectal temperature, a rectal thermometer. Readily available are the temporal artery and the ear thermometers. And then some people would do under the arm temperatures, but these are not accurate. And in the under 8 week age group, it's actually really important to have a very accurate temperature, like almost to the decimal point. Those other thermometers, you can swipe them 3 times in a row and get vastly different readings. So rectal thermometer, a temperature of 100.4 degrees or 38 degrees Celsius is a fever. That is an emergency. That's like in Monopoly. You don't pass go, you go straight to the ER. Other reasons to call your pediatrician or seek medical care. Any difficulty breathing. So first I want to back up and say, babies breathe in a very funny way. It's called periodic breathing. So they seemingly pant and then they seemingly stop breathing. I've gotten calls. I'm staring at my baby and she's not breathing at all. That is a normal breathing pattern, but persistent rapid breathing for like minutes on end, or with sort of head bobbing, nostril or nasal flaring, or sucking in along the neck or above the clavicle, sucking in between the ribs, like a baby's looking like he or she is constantly panting. That's a sign of possibly a problem. So you want to call your pediatrician or head to the ER if you feel it's more urgent than waiting for a phone call back. Another important sign, and I'll put these together, poor feeding and lethargy. So I told you babies are very sleepy. They can sleep all the time in between feeds. They can even seemingly sleep during a feed, but if they're actively suckling and you can look at that wide gaped latch and look and listen to movement in front of the ear of the jaw and watch and listen for swallowing, all these things that the lactation consultant in the hospital will talk to you about in terms of signs of whether the baby's getting milk. All of that can happen while a baby is looking like he or she is sleeping. And babies can sleep all the rest of the time in between those 8 to 12 feeds a day. But if you cannot arouse that baby to feed after 4 hours, the feed is barely happening, the baby's making fewer wet and dirty diapers, that is a really important sign that this baby could be ill and you need to touch base with your pediatrician. It's very important. So I want to highlight what has what has started in the last couple of weeks, and that's what the American Academy of Pediatrics started, which is the Call Your Pediatrician campaign. So everyone that's been calling me and paging me in the time of COVID has been apologizing more than they used to. When they call me, I think they think I'm getting inundated with like kids with COVID calls. We expect and want you to call us if you're concerned. And you need to reach out to us. We are one of your connections to the outside world, and we have an abundance of resources. We can actually accomplish a lot more with a telemedicine visit than you might think we can. I mean, just getting an eye on your baby and what he or she, or older child, and what he or she looks like can give me an abundance of information about what is going on. I spoke with a family this weekend on the phone, and we were talking and they were describing some things, and I said, you know what, let's do a telehealth. I want my eyes on your child, and we'll see if you need to have an in-person assessment. So I think that can be really important for us, and also for you to see us observing and evaluating your child. So please reach out to us. I can't say that enough. Also, going to the pediatrician for these crucial in-person checkups is really important. So that initial newborn visit, that 1 month check where we make sure that your baby is gaining weight, and we talk about how to stimulate your baby developmentally, and we assess your baby's physical examination and growth, that's key. at the 2, 4, and 6 month visits, all of those things need to happen as well. We need to look at with eyes on your child and the developmental milestones. We need to assess weight and growth, and your baby needs a heart exam and a belly exam at those visits, an eye exam as well. Things can be missed if they are not done in person. And then I can't, say enough how important the vaccinations, that primary series that happens at 2, 4, and 6 months is. When this pandemic sort of slows down and people are sort of more entering the world again with their families, children who are not vaccinated are going to be vulnerable, and there are going to be epidemics of vaccine preventable infection, again, like whooping cough, like measles. I mean, that happened last year because vaccination rates have dropped. So it is really important for your children to be up to date with their vaccinations, especially that primary series that happens in the first year of life. Okay. So let's talk a bit about some older children and specifically COVID-19. So this is now in this slide that I'm going to talk about active COVID-19 infection. We're going to get to the post-inflammatory syndrome next, so don't worry, those questions will be answered. So there was a study from China, reviewed about 1,700 children who are positive for COVID-19, which is the infection caused by SARS-CoV-2 virus. Most kids, that is greater than 90%, so this is the good news. This is the silver lining of everything that I've been looking at all along. At least I don't have to worry that much about my children. They, greater than 90%, have asymptomatic, mild, or moderate infection. So these kids don't need, intensive care unit support. Some of them may be admitted to the hospital, but they tend to have mild or moderate illness, which is resolving without sort of any sequelae or complications. Now, of note, infants and slightly younger children, so like 5 and under, are a little bit higher risk than sort of the older children. And the teenagers are actually at least risk for a severe illness in terms of the statistics that came out in this study from China. So this is the silver lining. You can go to the next slide. So I want to talk a bit about this because I know this wasn't touched upon in the last webinar because it wasn't happening that much yet. So in the last few weeks, the pediatric PIMS, pediatric multisystem inflammatory syndrome, or multisystem inflammatory syndrome in children, that's how it's called, has been described in the literature and in the New York Times. This is a hyperinflammatory response to the virus SARS-CoV-2, which is the virus, like I've said a number of times now, that causes COVID-19, the infection. It is an overactive immune response that is causing the detrimental effects on the body of the child it is impacting. It appears to be connected in time to a COVID-19 infection. And some of these infections are either asymptomatic, and we know that the child had it because they're antibody positive and maybe actually nasal swab negative, but antibody positive. So that's how we know that the child's likely had COVID-19 prior. But they don't tend to be contagious when they have this because this is usually happening after the infection. So it could happen either immediately after what could have been a mild or an asymptomatic infection, or weeks to a couple of months after the infection. And that's when parents or family members can sort of pinpoint maybe some mild symptoms that we're having that there were in the weeks prior. This, like I said, is not contagious unless the patient had a super recent infection and is in the acute phase, like still having had fevers and dry cough, active congestion, things like that at the time of the presentation with the syndrome. Most children did not have underlying illness prior to presenting with this inflammatory syndrome. So this isn't limited, unfortunately, or fortunately, to kids who, have underlying illness. You can go to the next slide. So the symptoms of pediatric multi-inflammatory. Typically, it's fever for 4 or more days, as well as 1 or more of the following symptoms. So I always say to parents, we use fever reducers to help, to treat the child and not the number. But say we give a fever reducer like acetaminophen or ibuprofen, so that's like brand name Tylenol or Motrin Advil. and then reassess the child about 30 to 45 minutes after treating a fever. And I don't care if the temperature goes down from 104 to 98.6. Like, we want to look at the child. It doesn't come down a little bit, but you want to see the child sort of perking up a little bit. He or she does not have to be acting like him or herself, but you want to see some improvement, a little perkier, a little more willingness to drink, sit up, interact better with parents, siblings, etc. So if there is minimal effect of these fever reducers, that is one of these additional symptoms to the fever for 4+ days. Inconsolability or lethargy and fatigue out of proportion to the fever. So a baby who is like a kid who is knocked out, won't get out of bed, won't move, is refusing to drink, that's a sign you need to call your doctor immediately, please. Any gastrointestinal symptoms, so abdominal pain, vomiting, and diarrhea. Generalized rash. So now I don't mean like a single hive or two on the face or something like that. I mean sort of a big portion of the body rash. Bloodshot eyes. So I don't mean like a little pink around the rim. I mean angry red, seeing the blood vessels of the eyes. That's what we're talking about. An enlarged lymph node, typically on one side of the neck, or gland, swollen gland. Peeling lips, or swollen or peeling, or both, hands or feet. These are the other symptoms we're looking for. I think the most important thing here, and I'm going to say this again because I can't say it enough times, if you don't like the way your child looks after giving a fever reducer, which is totally fine to do prior to calling us, call your pediatrician. I don't care if the other symptoms are present. It's better for us to assess on the phone or via telehealth, and then us to decide whether your child needs an in-person evaluation. So similar to Kawasaki's disease, which pediatricians and pediatric cardiologists and pediatric rheumatologists have been treating for decades, this disease can present similar to this. There are some differences. It can also look like toxic shock syndrome or cytokine storm, which you're going to say, what does that mean? I think the take-home point of these two is that these children are ill. They typically need intensive care unit support. Straight up Kawasaki's disease is often managed as an inpatient, but on a general pediatric floor. But these other two need another level of support. So these kids are quite ill. The evaluation for these illnesses, for this syndrome, needs to be done in person, and typically in an emergency department, a pediatric emergency department, because there is a lot of blood work and evaluation that needs to be done. And this is typically out of the realm of what's done in a general pediatrician's office. I just want to say that, but your pediatrician can guide you as to what needs to be done to work your child up if he or she is worried about what your child looks like. But the treatments can reduce, and typically do, the risk of the potential complications of the condition. Treatments are still being investigated, but the ones being used are similar to those we have been using, like I said, for decades for Kawasaki's disease. It is still not common. So even though there have been greater than 100 cases and plenty of kids being evaluated, including kids from our practice, it is still not considered common when you consider across the country the number of people that have been tested positive for COVID-19 infection. It is still not very common. So there is a little bit of a silver lining. This is still extremely unlikely to happen, even if your child does get infected with the SARS-CoV-2 virus and has COVID-19. Interestingly, also, this syndrome was not reported at all in the literature that came from China, but it was discussed in some of the literature that came from Europe. We don't know the answers to why this is, but hopefully more information will come to light, as it has been over the last couple of months. Children of all ages have been, treated and diagnosed with this condition. It's also, the most common age is ages 5 to 9, but it has also been reported in young adults. So people in their 20s are actually being treated by pediatric cardiologists and pediatric rheumatologists because they've been the experts all along in treating Kawasaki's disease. So they've been consulted in treating 20-somethings with this syndrome because their expertise lies in diseases, inflammatory processes like this. But I can't say it enough, and I have 2 stars next to it. Please call your pediatrician if you're worried about what your child looks like. Certainly 3 or more days of fever, and if any of those other symptoms are present, just call. And that's my practice, Premier Pediatrics.
Thank you so
Thanks so much for listening, everybody.
Of course. Thank you so much for doing that for us.
Great.
Okay, so now I'm just going to ask you a few questions, and then we will go into get as many of your guys' Q&A questions answered. If you two ladies can give me 10 more minutes, is that possible?
Absolutely.
I'm so intimate, like you poor thing. Okay, so first,
I haven't seen you drinking your coffee. All right.
good cup. Are children eligible for antibody tests?
So this is a really good question and a super common one. Right now, it is recommended to only do antibody testing in children in the setting of epidemiological studies. And then in grown-ups, it's also recommended to be used for plasma donation to hopefully treat some COVID-19 infected, individuals who are quite ill in the intensive care unit. The reason for this is two or threefold. First, we don't know the accuracy, the sensitivity and the specificity, those are like the statistically relevant terms to these antibody tests. And more information is coming to light, every week by week as to which tests are better than others. But there is potentially a false positive on some of these antibody tests. And this is because coronaviruses have been out for, hundreds, if not thousands of years, certainly hundreds of years. And so coronaviruses were one of the causes of the common cold. And potentially, if someone tests positive on the antibody, it might be because it's cross-reacting with one of those other coronaviruses that someone may have been exposed to and had in the past. And so then you would come home with a positive antibody test and think you are protected against a COVID-19 infection, but it's very possible that you're not actually. And then there's this false sense of security that can come. So that's one piece. Another piece is that we don't know how protective these antibodies are, or what level of antibody presence in a person is necessary to prevent a future infection. So this is all still being investigated. And until we know more, and until we know if the antibodies are protected, and if that protection is long-lasting, and how long-lasting that antibody protection is, I wouldn't recommend doing the testing, and neither would the AAP for that matter. So I think
just to piggyback off of that, like we as a practice have been trying to figure out when do we bring that in. And right now, in general in medicine, when we perform tests, we want to be able to have something solid to say to our patients, to be able to counsel them, and just the clinical utility of it. And I don't think that we're there yet. So I think over time, as we gain more information, yes, but I've just been trying to reiterate to my patients, like, if I order this test, I will feel in a sense baffled. I won't know what to back it up with, or to say, this is what in your case this means. So I think, patience is important in this aspect in terms of fine tuning it so we can say something substantial to our families about what it means.
Yeah, we can say if you're positive, but we still don't know what to tell you. That's pretty useless. It's a pretty useless test.
Great, thank you. My baby is 13 months. We still breastfeed, and it's likely that people in our household have contracted the virus. The baby seemed fine and asymptomatic. Since the baby was fine, will the baby always be fine and immune from the virus? Can you please shed light on a seemingly healthy baby's immunity to the virus? Is it likely that the baby is immune because of breastfeeding? Is it fine to have family members stay over and have small gatherings? So you just touched on immunity and a lack thereof in terms of antibody tests, but can you extend it a little bit to this question in breastfeeding?
So first of all, way to go to be breastfeeding your 13-month-old. That's wonderful. And certainly that can provide some protection for COVID-19 infection. They're analyzing actually antibodies from breast milk to see if there is some protective benefit that can be utilized in terms of treatments for COVID-19 infection. So wonderful. Your child may or may not have been infected with COVID-19. There have been family units where one member had it and others have not. So we have no idea if your child was asymptomatic, whether he or she had the infection or not, and testing doesn't tell us very much necessarily. So we don't know if your child is protected and if it's then safe to stop or decrease that social distancing that we've been doing now for 2.5 months. I can't say that any of that is safe at this point.
Thank you. In normal times versus now, how long is the baby immunocompromised for? How long do I need to cocoon for?
So in general, we say in the first 8 weeks, we want to be particularly cautious until by age, that baby, around 8 weeks, there's, a more evolved immune system. The baby is less vulnerable. And the 2-month vaccines confer some protection for vaccine preventable conditions. So usually we say, usually I'm telling parents, like, after those 2-month shots, you're usually okay to travel and be around more people, et cetera. Now, I would just be even more cautious in the first 8 weeks of life.
And beyond that, in the time of COVID?
In the time of COVID, I'd still be cautious. Yeah.
In terms of safety, should visitors wear a mask even after the newborn stage? Should they not hold the baby even if they have also been in quarantine?
So I said before in my slides that I'm recommending against sort of random visitors and getting rid of the social distancing and doing these socially distant like barbecues and things like that. I would recommend just not having visitors in the first place. Obviously exceptions are made for, as we talked about, like a grandparent who's coming to stay as sort of an extension of the family unit, or an aunt or uncle who's, holding the same role, who has quarantined before and then is staying with someone. But people who are coming and going, you're exposing your baby and your family to everyone that person has come into contact with, even if it's sort of, casual in the supermarket. You're just increasing the risk. So I would say it's just not worth it.
Should I be washing my breast before nursing if I am asymptomatic or may not have COVID?
If you're not ill, I don't think there's any reason to wash breasts prior to latching your baby onto the breast. If you're having symptoms, then that is different. Then I would mask, monitor symptoms very cautiously, hand wash, and wash the breast for any respiratory droplets that may have come in contact with the bare breast.
Thank you. Do I need a car seat to take my Uber to baby appointments?
You would need to use your own car seat because Uber car seat is only for 2 and older. There are a lot of beautiful videos on how-tos to install a car seat on YouTube. The car seat lady is a phenomenal resource for how to install a car seat into, a taxi or an Uber. I used it myself, to be honest. I'm a pediatrician, but I'm, not a car seat installer. That's for sure.
And then Uber car seat is only for 2 years plus, is that right?
Correct.
Okay, so we are gonna move on to the Q&As. The first question is, are there rules around what the in-laboring mother can drink and or eat pre-delivery should we come to the hospital having eaten something?
I think in general, our recommendation that if women are in early labor, when contractions are just getting going, which for women having their first baby, they typically have, some time at home. So having a meal that's a little bit more substantial. I wouldn't do anything like really heavy, but something that will give you, we're trying to give you kind of things that will keep your energy going. Once in the hospital, we still allow patients to do clear liquids. Our clear liquid tray, it's kind of fun, maybe not so fun. There's a little bit of like Jello, there's juice, there's ginger ale. We're okay as a group, as people, kind of, that's where the snacks come in, doing like small snacks, maybe a small bar, or like the crackers or something, because you're going to need some energy to keep your body going. But most women, first baby, second babies, as they get into active labor, they don't want to eat. It just becomes more about like hydrating, and that's the way to keep their energy going. So I don't think that there's any, things that we tell patients, stop eating by a certain time if you're coming in with contractions. I think listen to your body. I think if you're early in labor, You can have something a little bit more substantial, but you'll see things like coconut water, vitamin water. They have these really cool things that actually I eat too, but they have really cool fruit bars that are like mango and strawberry that sometimes we have them on the labor floor. Our partners will go get them from the cafeteria and they're like delicious. So it has a little bit of carb in it to keep you going. But those are kind of our restrictions. The only time we really restrict food is that if moms are coming in for like a scheduled C-section delivery, then they are fasting for sure. But that's the only time we restrict.
Thank you. Should my husband and I get tested for COVID now? Is testing offered at your office? I'm in week 31.
I think because although testing is slowly, as you hear everyone talk about it in the medical community and the updates from the governor and the mayor, the testing is becoming more widely available. I think still our thought is limiting it to people who are symptomatic, but still doing that general screening in the hospital to help know where patients need to labor and deliver and recover. Obviously, if there are respiratory symptoms or concerns, and I would say for sure testing, but I think for now until like there's, testing that's widely available, I don't necessarily know that I would say go forth because then that would also require you going out into the community. We haven't been screening anyone in our office because we don't have the ability to do, there's particular protective equipment that you have to wear, there's particular specimens and how it has to be processed. And in the outpatient office setting, that hasn't been maximized or really worked out in a way so that we can get things collected in a safe way into a lab. So I wouldn't, if you guys are healthy and have been at home for it, I wouldn't recommend testing now.
Great. Will NYU's care package include a sitz bath or should I buy one ahead of time?
I think most people get them from our postpartum floor. Like I feel like they have a small sitz bath you can take, or there's also like a little donut inflatable. A lot of women like it just because having a little cushion underneath them after they have a vaginal delivery. If they have some tearing, both of those things are helpful. Nurses will also give like ice packs. They'll send you home with a few ice packs or like witch hazel pads. Remember, you can also make like padsicles at home. So those are simply, you can take pads and actually pour. Dr. Collins used to work with us, used to tell patients to take a shot glass of witch hazel, pour it on the pad and put it in the freezer, or just freeze Tux medicated pads that have witch hazel. So then remember, it's cooling, it's anti-inflammatory, so that's helpful. But they still are, and then sometimes they'll send you home with a few diapers as well. So there are a lot of things that the nurses are great. They pack you up. Actually, I still have my little purple NYU bag from like 5 years ago where I came home with my goodies. But yes, those are things that you can get from the hospital.
Great. If we decide to circumcise our baby, do we need to inform the practice early on? And will this circumcision occur within 24 hours of delivery?
A lot of people have been asking, so we're still doing circumcisions. I know some people are like they're an elective procedure, but we've been doing it throughout the pandemic. So it is done by one of the obstetricians, so one of the Downtown Women team, and it's normally done the day after delivery. So babies need to be eating, drinking, having wet poopy diapers, being seen by our awesome pediatricians like Dr. Capiola, and then they give us clearance. So we do it the day after. We will start, as women get closer to their delivery date, we'll start to ask in the office if they are wanting to do a circumcision. So we'll document that in the chart. We can answer some questions for you about that if families have questions. And don't feel like we're annoying, but we tend to ask again after delivery because some families do change their minds. And I have had families change their minds even up to the point of, I've gotten the consent and I'm wheeling the baby to do the circ, and then the dad steps out and is like, no, we're not doing it. So it's not that we're being annoyed. We just want to make sure you have all your questions answered and this is a firm decision that you're making. But yes, circumcisions take place the day after, not in the delivery room, normally the day after with one of the OB team members.
Great, thank you. We have 3 more questions, but we are way beyond time. Should we answer them or should we just say goodbye? If you want to give really, really short answers to all of them.
We can answer.
When and how should we be reaching out to pediatricians during this time to set up first appointments if we don't know when the baby will be born? What week should that be?
If you want to do a prenatal consult, you can call, while you're pregnant and set that up. So just so that it's a meet and greet, and it would be usually telephone or virtually, like a telemedicine. Otherwise, if you've already decided on a pediatrician, you just call when you know you're leaving the hospital and arrange for follow-up. We make it work.
What week during pregnancy should they call the pediatricians?
Anytime.
Anytime, but I definitely, like, if you wanted to give a deadline by the time you're 37 weeks or early term, just in case you go into labor early, like, you have everything set up. And I know it seems very nebulous, but Dr. Capio is right. I'm sure what you do in your office is they kind of block newborn appointments because they know families will be calling, and then they move you into the schedule.
We always make room to see you, so don't worry. You can, and even on the weekends, they're the only ones we're seeing in office on the weekends, or newborns that need to be evaluated within 1 to 3 days of discharge.
Do either of you have an answer for how to deal with living in an elevator building with a baby? I guess sharing elevators.
Good question. I can tell you from the perspective of our working in our office, because we have to go up to the 3rd or the 4th floor, that at least in the office setting, a lot of people have been very cognizant about not crowding elevators, or you'll even have some people that I'm going up in the morning, they ask, can I go by myself? I mean, I would think it would be fine if it wasn't, a crowded, I'm thinking a crowded subway train, but if there's 1 or 2 people, everyone's masked, I don't think that would be a problem. I mean, in the hospital, we get on and off the elevators all the time with each other, and what NYU has is just a sign to say, please make sure you're wearing your mask while you're on there. So
the primary mode of transmission isn't going to be in the quick encounter that's going to happen. So we're not just looking at the physical distance. Even 6 feet for an extended amount of time, that's higher risk. But brief encounters like what happened on an elevator, and again, you can ask to go on your own or what have you. But I think that's still a pretty low risk scenario.
Great. All right. Thank you so much, ladies. We really appreciate both of you. Thank you, Dr. Capiola, for joining us today.
Thank you for having me. Thanks so much.
Pleasure. And Dr. Whitehead, you are a powerhouse. I cannot believe you could call all night, slept 2 hours, and are here today for everyone. When you see Dr. Whitehead, shower her with gifts.
I'm so happy. I'm so happy to be here and do this. It's great. It's great.
Great. Thank you guys so much for joining us, and please fill out the feedback forms and send me any questions or comments or ideas that you have. Thank you so much.
Okay. Thanks.
Bye.
Saturday.
Bye.
Get outside and enjoy the weather.
At social distance.
Wear your mask. Wear your silk scarves.
Yes, that's right.
Okay.
Bye.